Hey everyone, welcome to another emdocs.net videocast. And today we're going to look at another EBM update. Our topic is going to be intravenous blood pressure medications in patients with neurovascular emergencies. To help us with that, we're going to look at a systematic review published in Neurocritical Care 2022. The title, Comparison of Intravenous Antihypertensives on Blood Pressure Control in Acute Neurovascular Emergencies, a systematic review. The primary question was in patients who present with an acute neurovascular emergency who requires blood pressure control, is one agent more efficient and safer than the rest? This was a systematic review of databases up to August 2020 using PRISMA guidelines. They included RCTs and non-randomized studies of patients with acute neurologic emergencies. They define this as hypertensive encephalopathy, ischemic stroke, intracerebral hemorrhage, subarachnoid hemorrhage, and TBI. Studies looking at other hypertensive emergencies were not included. The antihypertensives included nicardipine, clofidipine, labetalol, and finally nitroprusside. Bunch of different outcomes here: mortality, functional outcome, blood pressure variability, time to goal blood pressure, time within that goal blood pressure range, episodes of hypotension, and then need for rescue antihypertensives. Let's get to the results. Authors initially found over 3,800 titles. Ultimately, they included 10 studies. Only 2 of those were RCTs. All right, so let's get to the different comparisons. Comparison number 1, nicardipine versus labetalol. 5 studies, 413 patients. Mortality and functional outcomes were similar. For nicardipine, 2 out of the 5 studies showed less blood pressure variability, greater time within blood pressure range, and faster time to blood pressure control. 3 out of the 5 studies showed fewer antihypertensive measures were needed. Comparison number 2, nicardipine versus clofidipine. This was 3 studies, 386 patients. Authors found similar mortality rates. 1 study found similar blood pressure variability, similar time to blood pressure control, and time within blood pressure goal, but the estimates favored clofidipine. There was also similar need for rescue interventions. The final comparison, nicardipine versus nitroprusside. 2 studies, 1,563 patients. An observational study showed lower mortality with nicardipine. There was similar time to blood pressure goals and time within the blood pressure goal. Let's look at some considerations when it comes to this systematic review. This review does ask an important question. We see patients with neurologic emergencies who require blood pressure control. They did follow PRISMA guidelines. However, they included both RCTs and observational studies. And anytime you combine different study types into a systematic review, it causes some problems, like high risk of bias and significant heterogeneity, and ultimately poor quality data, which leaves us with some limited conclusions. Let's spend a couple minutes on the PRISMA guidelines. This is the preferred reporting items for systematic reviews and meta-analysis. PRISMA was designed to help researchers discuss why they did what they did, detail what they did, and what they found. On the PRISMA website, they have a 27-item number checklist, which helps authors construct a high-quality systematic review. The bottom line, in patients with neurologic emergencies and hypertension, you have options for your blood pressure agent. Pick a drug, know how to use it. Personally, I like nicardipine. It's easy to use, it's titratable, but I tend to avoid nitroprusside. We've been talking about different blood pressure agents, but what's the specific goal blood pressure that we should be shooting for? Well, that number is informed by two studies. The first one is the INTERACT 2 trial published in the New England Journal of Medicine 2013. This was a multi-center RCT that randomized over 2,700 patients to strict blood pressure goal of less than 140 or more lenient of less than 180 for their systolic pressure. The primary outcome was 90-day mortality or disability. There was no difference between the separate groups. However, there was a difference in a controversial secondary ordinal analysis in the more strict blood pressure group, but again, overall, based on the primary outcome, this was a negative trial. The second study was the ATTACK 2 trial published in New England Journal of Medicine 2016. This multi-center RCT randomized 1,000 patients to a goal blood pressure of less than 140 versus a systolic pressure of less than 180. Similar primary outcome, 90-day mortality and disability. Again, no difference between the two separate groups. Let's take a quick look at our guidelines here. We have the 2022 guideline for the management of patients with spontaneous intracerebral hemorrhage, a guideline from the American Heart Association and American Stroke Association. Their first recommendation is that in patients with spontaneous ICH who require acute blood pressure lowering, careful titration to ensure continuous, smooth, and sustained control of blood pressure can be beneficial. You want to avoid peaks and large variability. Their second recommendation is that in patients with spontaneous ICH in whom you're considering acutely lowering their blood pressure, you want to initiate treatment within 2 hours of ICH onset and reach a target within 1 hour. Their third recommendation is that if they present with a systolic blood pressure between 150 to 220, acutely lowering to a target of 140 and keeping in the range between 130 to 150 is safe and might be reasonable to improve functional outcomes. However, you do want to avoid dropping that systolic pressure less than 130. That is potentially harmful. So those are the guideline recommendations, and again, those are primarily based on ATTACK 2 and INTERACT 2. Ultimately, I think there need to be a couple caveats here. You need to base your decision on the patient in front of you. For that patient who walks around with a blood pressure of 250, that's what their body is used to. If they present with ICH, give them an analgesic, and then start to lower their blood pressure. The last thing you want to do is reduce the cerebral perfusion pressure or cause other end organ injury like an acute kidney injury. In conclusion, we talked about intravenous blood pressure medications in patients with neurovascular emergencies, and finally, we touched on the AHA-ASA ICH guidelines. Thanks for listening, and stay safe and healthy, everyone.